Now, we're going to start this week's show looking at the knee. Now, rather than looking, and teaching to suck eggs, I just want to bring your awareness to some key points when you're actually doing your knee joint assessments, okay? And the big kind of thing that I want to focus on first is if there's a knee joint effusion in the actual knee, okay? Now, from clinical experience, the sweep test is very, very useful, okay? And whenever I've sent guys or girls for MRIs, especially in sport, that sweep test was a really, really good indicator of if there was an effusion in the knee joint itself, okay? So the sweep test, all we're going to do first and foremost is we're going to go down into this VMO, okay? So where the VMO attaches, and we're just going to sweep up, okay? So we're going to sweep up, and then I'm just going to come down the outside of the vastus lateralis, and I'm just going to rub that vastus lateralis, and I'm going to go down. Now what you'll usually see is you'll see a pocket of fluid. So I'll get you a cutaway clip here of an actual positive, okay? One of my good friends in a physio actually had one of these, okay? So we'll get a clip of that, but you'll see a pocket of fluid usually emerge in kind of that space where that VMO attaches, okay? So that's going to be really, really useful for you in terms of a key performance indicator that I always talk about in terms of actually progressing your athletes. So that's going to be something that I personally take a very, very keen interest in. Now, if that's quite acute, I'm not a massive fan of letting athletes train with a knee joint effusion, okay? Yeah, there is research and literature out there looking at knee joint effusion and muscle inhibition, etc., but it just doesn't sit comfortable with me in terms of risk reward. And usually if it's acute and then the rest of these tests that I'm going to go through in a sec are negative, then usually these will settle down, quite quickly, okay? But if an athlete has a knee joint effusion and they're continuing to run it and that effusion's getting bigger and bigger, okay, then, that probably to me means that these tissues are continually to get irritated, that we're not finding the true cause, and that these tissues in the knee joint is continuing to get stressed, okay? So that sweep test is going to be a key performance indicator that I would encourage you to use session by session, okay? And ideally after kind of 2 to 3 sessions, we want this gone in the private practice, okay? So we want that knee joint effusion to have resolved itself, okay? If that knee joint effusion continues to hang around, okay, and it's an acute injury, and that's just making me think, okay, why is the nervous system, the brain, hanging on to this knee joint effusion? Why does it think that it needs to have this at the moment? Okay, what's it trying to protect? What's it trying to heal almost? Okay, so that's something to take into consideration. Now, in terms of meniscal tests, okay, I can say hand on heart that I have never, in 10 years of professional sport, had a positive McMurray's or a positive Aspley's. Okay, and that's what I meant in the first episode where I said the special tests, they're not really that special at all, and we know that they're not great. Some tests, some are a little bit better than others, so it's putting the whole picture into consideration with the mechanisms, with the injury history, with the person's story, and starting to make sense of that. But the one thing that I will say that I found clinically to be very valuable is overpressure. Okay, very, very simple. So that knee joint extension, we know that's going to stress the anterior meniscus a little bit more. Okay, do they get a nip? Are they lacking knee joint extension? And then the big one for me that I use, okay, is a lot of overpressure. Okay, so again, I'll get this ankle joint and I really want to push that heel to the bum. So again, obviously we're going to stress more the posterior compartments of the meniscus at that point. So if that person has a knee joint effusion, they've got joint line tenderness, okay, and again that kind of pinch in the back of the knee with overpressure, then we're thinking, okay, maybe the meniscus is irritated, okay? Now the difference between a stable and unstable meniscus, you'll probably be able to tell based on that person's function, okay? So my higher level knee joint exam, when I get them in standing again, that would probably give me more of an indication then whether this is stable or unstable, okay? And then another indication of whether this is stable, unstable, or problematic will be how quickly this knee joint effusion settles and how quickly that pinch in the back of the knee settles as well in the next session, okay? So it sounds obvious, but time is very, very useful as well to see how quickly it settles, okay? So That's the first big thing, is don't be afraid to use overpressure. Now, just because the patient has a pinch, they've got joint line tenderness, don't forget the majority of the tenderness that you're actually feeling, okay, is coming from the knee joint capsule. Okay, the amount of receptors there, okay, that combined with the effusion or some whatever is in there, okay, that's probably the majority of what you're actually feeling. That meniscus doesn't have any receptors, okay, so again, it's going to usually be the capsule and the actual the effusion that's going to contribute to that pain experience more so than the actual directly that meniscus. Okay, so obviously, yeah, the meniscus having some trauma is probably going to cause the effusion, cause the capsule maybe to react a little bit, and then clinically when you're touching that capsule, you're eliciting that pain experience. Okay, so just keep that in mind. So then if we can desensitize this knee capsule, okay, then very often we can take away a lot of these kind of pinches and stuff like that. We take away that pinch, we maybe just want to keep that range, we want to find, then that's my 20% done on the knee joint. My 80% then is focused on what's causing this knee to overload in the first place if there wasn't a mechanism. Okay, they come in the next session, and then we're looking at our key performance indicators. In this scenario will be my knee joint effusion, overpressure. Okay, have I kept the gains that the person left with? Okay, if we've kept them, great. It means the loading that we're doing now is appropriate. It hasn't caused a negative reaction. To come in the next day, they're worse. Okay, the knee joint effusion's huge. I'm like, okay, first thing I'm doing is, okay, tell me about your week. What did you do? I want to question them a little bit more. Maybe they've gone, you know what, I felt great, so I said I'm going to have a run. Okay, again, because we've only taken that 80% true cause through a small level of loading, that person wasn't ready to run. That's my fault. I didn't have effective explanation in telling that person the plan for the next few sessions. Okay, so I need to take responsibility with that just as much as the patient does. Okay, we need to look at ourselves as well. Okay, so that overpressure, it's a very, very useful test. Okay, it's obviously going to stress a lot of tissues, you know, along the surface of the patella and obviously along the joint line as well a little bit. Okay, so really, really useful test over pressure to get these meniscus. But again, combining that joint line tenderness and knee joint effusion, the three of these clinically for me have been absolutely vital over the years. Okay, so the next test that I want to talk a little bit about is the actual MCL. Okay, so when you're stressing the MCL, you want to have intent with what you're actually trying to do. So I see a lot of new grads and I see a lot of students, etc., when they're actually stressing the MCL, and if we do it from this side, okay, when they're actually stressing that MCL, okay, is they'll just go through the motion. So what you want to be doing is you want to find the joint line and you're trying to gap that joint line on the inside. So as I push, my intent wants to be pushing in that direction through that medial joint line. I want to gap that medial joint line, okay, and I want to see if there's any pain response, okay, if there's an end feel. If you do this and it gaps massively, don't worry about it, okay. One of the world's best number 10s rugby union player that I've worked with, when we done this MCL with him, I was assessing him, it kept going. And he said to me, don't worry, I've done my MCL a few years ago. Okay, so again, a lot of these people, they may have done these MCLs in the past, and you know, from my experience, they don't knit down very well. Okay, so when I was in Australia this year, we did an MCL, or last year for the Rugby League World Cup. Went to a surgeon in Melbourne, and he was saying, look, the knee joint, the biggest thing with the MCL is that it's stable in extension. Okay, so again, with that knee extended, and we're going to gap that knee, we've got that solid end feel, brilliant. Okay, you can obviously do it with more of a bent knee, but then it's a little bit harder to get that true valgus stress as well. Okay, so that's a big one, is joint line pressure as opposed to just going through. Okay, so again, if my hand's here and I'm pushing with my fingers here, you know, I'm probably pushing that way. So I want to have my thumb, my hook hammer, whatever you want to use, and that's direct pressure through that joint line. It's the same with the MCL. I'll usually come in here and then I'm right on that joint line and I'm almost pushing that way to gap. And again, I want to feel that end feel. You can see Pete there. Okay, so if I do it dynamically, that force is going pretty much in the frontal plane. Whereas when I get into knee flexion now, it's just getting a little bit harder. I can still gap it, but there will be a little bit of rotation, okay, in the transverse plane the second I flex Pete's knee, okay? You can still do it, but just keep that in mind as well. So definitely want to check it extended, a little bit flexed, okay? With the MCL, one of the key performance indicators for me with an MCL is full knee flexion pain-free. Okay, so with a lot of these MCLs, you can have a patient and they're just getting a little bit of a nip in knee flexion, especially if you decide to brace them. Obviously that knee is going to get a little bit stiff. Once you get that flexion back, I love, okay, and for me it's one of my KPIs that they have to have that full knee flexion before we start running, okay, because you might get away with low level jogging at the moment, but you'll get found out when you ask that athlete to go above 80% usually. So as they start to sprint and they open it up, they'll be almost dragging the leg rather than letting that heel come right up to the bum as they sprint. Okay, so I like that full knee flexion to be restored. And again, it makes sense. If there's trauma to the MCL, there's going to be probably trauma to the knee capsule as well. That knee capsule is going to tighten as we flex the knee. That capsule has to lengthen. Okay, so it's pretty important to desensitize too. For the ACL, I like the Lachman's test. Okay, so again, if you are doing your anterior draw, the one thing I would say is just try take up the tendons. Okay, so again, when you compress and load that tendon, that's going to help the hamstrings, the gastrocs to relax a little bit. Okay, and you can do your draw. Okay, you can do your posterior draw. I had a guy the other day that I was suspecting, and again, I want to give it a good bit of force, because again, I would rather be a bit aggressive here and just irritate him a little bit rather than not be aggressive enough and miss it. Okay, but for me, for an ACL, I like a Lachman's test. Okay, so all I'm going to do here is I'm going to keep the knee like this. I'll put my hand on the quad. I'm going to take up the slack through the tendons again, and again I'm just going to pull up, and what I want to feel is a good end feel. So I'm taking up the slack in the tissue and my force is going straight up, okay, in one single movement, and am I blocked with a good end feel? Okay, to get that good end feel, I'm very, very confident. If you have one of these straight after a game and they've just come in from the dressing room or from the field, okay, don't worry if you can't really feel an end feel. Again, the hamstrings go into quite a bit of protective tone, etc. Okay, so it's one that it can give you a false positive very easily. But again, the next day, effusions, knee joint effusions, that's going to give you a clue, although I've seen ACLs as well with very, very minimal knee joint effusions. Okay, so again, if it's just the ACL, there's no meniscal damage, etc., sometimes they don't swell up. Okay, so that are the big ones. I'm trying to think: ACL, MCL, LCL, PCL, the meniscus. They're the big ones that we'd want to check. From a more of a knee joint assessment, from non kind of traumatic knee joint, you want to consider the difference in knee joint range of motion, prone to supine. So again, when we look at knee joint flexion, okay, the distal tissues are going to lengthen more, while the proximal tissues aren't required to lengthen. Whereas when the athlete's on his front and we get his knee to his bum, then all the tissue, distal and proximal, are going to lengthen. Okay, so again, I'll give you a clue there. Start clinically reasoning the difference in tissues that are required to lengthen. And maybe it may be more appropriate then to focus your attention on the tissues that need to lengthen in those specific scenarios. So again, that's just your 20%. We still want to find out through our assessment the key 80% of what's not doing its job to cause this quad or this knee joint to take excessive load. Okay, so 80% of my attention then is going on that, and that's what I would have found out with my assessment. Okay, so as I said, what I've just shown you today, that's finding the 20% that we're going to respect, we're going to desensitize. But the big thing now we've left as we go through our assessment, which is a whole body assessment, is what caused this to take excessive load in the first place. Okay, so any questions, any comments, post them in the comments of our YouTube page, or you can put them on our Facebook page, and more than happy to get back to you.